lucky last speaker is Professor Julie Redfern, who is a physiotherapist and Professor of Public Health at the University of Sydney, and also an NHMRC investigator grant holder. Welcome, Julie. Looking forward to hearing your talk.
Thanks, Lauren. Thanks for having me today. It's very nice to be invited to present some of my research. And I am very thankful to Professor John Chalmers, who nominated me for this fellowship and can't be here at the moment, but he's been a lovely mentor for me over a long time. So I'm using the term, as Clara said, we were given sort of free rein on what to talk about. So I've chosen to use this term growing up as a health and medical researcher. It's a phrase my colleague Carolyn Wu and I use regularly, and it's about being born as a researcher and then turning into an independent researcher. So as Claire has already alluded to, and I don't need to go into much here, we know that cardiovascular disease is the leading cause of death and disease burden globally. And we have an aging population and more people surviving the initial events, as Clara also mentioned. So in Australia, we know we have almost 60,000 people experiencing acute coronary events every year. But that actually means, luckily, thank goodness, as we're getting better, a lot of people are surviving. So that's where my research has come in. We know that CVD is chronic and it doesn't resolve spontaneously. So there's lots of people, in fact, increasing numbers of people needing support and ongoing care. So there's an urgent need for improved long-term risk factor management. So this is a sort of a timeline I put together, and really the area of work that I'm going to talk about today and has become a bit of a focus of some of the things that I'm doing. And basically, if we go back in time, we know that, prior to 1950, people were put on bed rest after a heart attack. And you may or may not have thought about that. I'm sure you have. And people sort of needed rehabilitation after being in bed for 1 year. Often people weren't even allowed to get up to walk to the bathroom because there was a fear they would have another heart attack. So in the 60s, we saw some pioneering research at the time that people could actually sit safely in a chair and even walk around in the hospital. And this was quite controversial at the time if you go back and have a look at the literature. But obviously it's led to a change in the way we do things. And, physical activity was not advocated at this time. So around that time, we saw the emergence of this sort of outpatient cardiac rehabilitation programs, and that's where my research has kind of built from. But basically, we saw people having bypass surgery, and people did have very intense, long periods in intensive care. So people had been on bed rest and were very sort of mollycoddled, if you like, and needed this kind of outpatient rehabilitation programs. And so we saw this proliferation in the 80s and even a bit earlier of these group-based programs in the Western world largely. And that included and extended from being mainly focused on exercise to get people moving after they needed rehabilitation along with education. And we saw the emergence of the Framingham risk factors and other things as well. But over time, of course, bypass surgery has become more straightforward, still very complex, of course, but also the emergence of percutaneous coronary intervention where people just need day stay and it's much less invasive. But we still see the majority of our cardiac rehabilitation programs, in fact, 70 to 80%, perhaps more globally, remain largely unchanged during that 50-year period. And that's what my research has been about. And of course, we see the huge change in society, focus on language, culture, technology, and of course, equity and other things, and obviously a change because of the pandemic. So basically, this timeline became the focus of some work that we've been doing and showing that really these cardiac rehabilitation programs, why are we still doing what we started doing 50 years ago, despite enormous change in health and medicine over the same period? So now to sort of go back to the growing up phase. So I am a physiotherapist, proudly allied health professional. And, I started working at RPA Hospital in 98 and Concord in 99, and I worked in the cardiac rehab unit there and got involved and met some of my continuing mentors today. But then I went and lived in Greece for a year, so I didn't work. So I think that's always nice to say that, it's not always flat out work. But I really had a focus even from my PhD when I came back from Greece about the patient. And I think that's relevant to some of the earlier conversations and questions. And for me, it is about being patient-centered and being focused on what each individual person needs, as opposed to a kind of lift packet program for everybody. So I'm a very big advocate for that and have been my entire career. So the other part about this journey, I think, to overlay is kind of my son, and he's just sat the second English exam this morning for the HSC in New South Wales. But, you know, this all started, he was born during my PhD. And I have been a single parent to him the entire time for my career. And I think that's something it's good for me to remind people and highlight, that what I've done often has been part-time and being a parent, and it's encompassed the entirety of my son's life. So this is kind of going back, one of my PhD papers, you know, a bit similar to sort of Clara showed, that early work has actually influenced the work that's still happening today. So one of the earliest papers that I published was about showing that people not participating in the existing cardiac rehab programs often had the worst risk factor profile. And you might imagine that the people who felt confident and more active were the people rocking up at the programs. So my whole PhD was about the people not turning up to the programs. And I devised an intervention called Choice. So it is based on the person having choice in their own treatment. And that was back, we devised this in about 2004. And then it had telehealth before the time of apps and things. We published that trial in Heart. And we found that giving people choice over the way they would manage their own cardiovascular health and other elements of their health, heaven forbid, it actually was helpful. So then I went on and kind of became an ECR, I guess. After my PhD, I did move to the George Institute, where I was in the cardiovascular division, and I actually met Clara Chow for the first time. So it's kind of fortuitous that we're both speaking very closely here. And I got involved in the snapshot study, which I won't go into, but basically this was a kind of career-changing thing a little bit for me, because I became involved in a very large national study where we looked at most hospitals in Australia and New Zealand, and I met more amazing people and was able to have a key role in that big study, and also took on my PhD student, Karis Huon, who now has an investigator grant and still works with me at the University of Sydney as a postdoc statistician. But so the research I was involved with was what happens to people after hospital. And we found that, you know, we know that most people don't get the prescribed medicines they should. Only less than half even are referred to our rehab programs, and not everybody gets the advice they should get, or for example, Indigenous health workers aren't seen where relevant. So basically, we also looked at who got sort of a combination of the bare minimum, and we found only a quarter of patients. And the data don't lie, because this is kind of data collected from all sites. And we sort of thought this was not good enough, of course. So then we've done a whole range of trials in different things, digital health, trying to sort of overcome this problem. One of them was the Connect study, which David Piris and Nushka Patel, myself and others were involved with and led at the George Institute. We developed an app, but the difference about this app, basically at that time, it feels so long ago and so early, but it was integrated with the primary care software. So the data would feed into this, and patients didn't necessarily have to upload any information. So people could learn about their condition, they could set goals and act on things, they could share information, and obviously other things like tips and things like that. So we've published that in the Nature Digital Medicine Journal and found that, you know, it wasn't everything good for everybody, but it was good in some ways in some of the outcomes at 18 months. So I think we do need more research on some of these digital health things. And here's Clara, because we have done a lot of work in the text messaging space together, as Clara has already highlighted. So a lot of projects there that has expanded into a lot of areas. Another study led by actually Clara and my PhD student, Carla Santo, who was a cardiologist who came to us from Brazil. I think it's interesting, and I put it here, it was called MedUp. And I think it was interesting for a PhD, she was funded by the Heart Foundation, was because we actually took what was already out there in terms of apps for managing heart disease and see whether they were effective rather than constantly building new technologies. And she found that an app did improve adherence to medications, which was her focus, but a more complicated app wasn't necessarily any better than a more simple app. So I think that's quite a nice, neat study that she did. Before I just finish off on the bigger program we're doing at the moment, I do want to touch on 2 large primary care studies that I've been involved with, along with others, both funded by the NHMRC. One led by David Pires was called Torpedo, which was a cluster trial, and Quell, which I'm leading, is also a cluster trial. In both in primary care, we've got a lot of practices and a lot of patients by collecting data remotely and virtually, and never seeing a patient in either study. So we use auto-extracted data, and I learned a lot from the Torpedo study and the Quell study. We've taken that another level and used data for the intervention, and also have linked it, the primary care data, with all of the state and national administrative data. So that's been an amazing journey. And then we've taken that into cardiac rehab, because we know back in the day we used to keep data or patient records like this, and cardiac rehab, you may or may not know, pretty much still do this. It kind of falls between the crack of a hospital and primary care, and tends to get a little bit left out. So we've got an MRFF grant to work on this space at the moment. And this is the quality improvement intervention in Quell, which we're now mimicking in our quicker study led by Professor Robin Gallagher at the University of Sydney, who's a nurse. And basically we use data to help drive better performance and outcomes for patients. And then I guess I just wanted to show this slide to say that, I guess for me, in about 2018, everything started to kind of come together. We had this sort of cardiac rehab space, we had evidence practice gaps, I had collaborations, I had grant success, and I had experience with data linkage and using data in large clinical trials. And I applied for a Synergy grant in the first round of the Synergy grants, and we were successful in getting this, and now we've emerged on our Solve CHD program that really has taken this cardiac rehabilitation space from a kind of very underfunded, very sort of misunderstood in one way space, to actually having some very serious research support to help drive it. So I'm working with a bunch of amazing people. I couldn't show them all here, but really we're about finally coming together to solve this problem. And we want to get that national system to have data and reporting platforms about cardiac rehab, moving from pieces of paper. But we're also supporting innovative research projects, a huge capacity building program, and a big network to actually bring everyone together, which is what Synergy grants are about, so that individual projects, not so much, but everyone coming together. And that's been what we've been very successful in achieving. So you can look us up on our website or on our social media, but through this program, we've got this huge group of previously unfunded ECRs, I guess, and other students. We have lots of members, lots of institutions now, and we have, I've only listed a few there. I've listed 10 projects. In the suite of work, we've got over 5 MRFF grants plus other fellowships. But what's important is it's all about coming together and all being on song to try and actually solve the work together, which is what we're doing. So that's a photo of the amazing team. And I guess I just had a slide to finish. This is a bit of a diagram of some of the authors from Australia in the space of cardiac rehabilitation. And you'll see my amazing colleagues, Tom and Robin, feature very strongly, as well as some of our others. And I've just got some photos there of some of the amazing people that have worked with me over the entirety of my son's life, now 18. So thanks, and hopefully there's a question or two.
Just reflecting on the theme of this conference about driving health equity, of course, kind of digital health interventions have got great promise for things like reaching people who live rurally, or reaching people who otherwise would struggle to meet centralized services. But how do we guard against the kind of emerging evidence that many apps and technologies still leave people marginalized, who are the least health literate, the least linguistically able, the least engaged with shared decision making and their own care? How do we meet that tension in your view?
Yeah, I mean, I think it's a really good point, and I don't think that technology is the answer to everything. I think I went up to Darwin, it was quite a few years ago now, and you know, I learned that there was one cardiac rehab nurse for the entire Northern Territory who worked 2 days a week, and you're like, okay, so how can we obviously do this? And obviously, this is one of the passions that I have. These face-to-face traditional ways of helping people and working with people are not going to service those 50,000 Australians who we cannot run those kind of programs. So I don't don't necessarily have the answer, but what we can do is try and have the data to understand exactly what's going on and see who's who. But I mean, you think about something like School of the Air, I mean, and how effective education has been in these remote communities through, you know, use of technology, which was, you know, very old radio style initially, and then maybe bringing people in, you know, but these kind of models have been working in education, and it's a hybrid, I suppose. But I think we can learn from some of the things that are successful. I think, you know, School of the Air to me is a really good example and something that really resonates with me about, you know, accessing these communities. But I mean, it isn't going to, we cannot see everybody one-on-one, you know, and do these intensive programs. So it is very complicated. And I don't have the answer, but I think there's a lot to think about. And I think it's really important that we do think about it. And, you know, clinical trials, obviously, as we know, they don't include everybody, and that's a problem. So that's where using trials like these other ones that we've done where we use data, you actually can include a lot more of these people that are often marginalized from clinical trials.